So now let's start with the individual bleeding disorders. The first one will be a immune thrombocytopenic purpura. So don't confuse, it is not idiopathic, it is immune thrombocytopenic purpura. It is an immune mediated disorder, right? So in this, there is going to be formation of autoantibodies. Okay, autoantibodies are formed against the platelets. So autoantibodies are going to be formed against a fixed antigen on the platelet. So it is going to be an example of the type 2 hypersensitivity, and usually the presentation is below 40 years of age group, and as an autoimmune disorder, it is going to be common in females. So this autoantibody is usually of the IgG subclass. So IgG autoantibodies are going to be present against the platelet glycoproteins. So against platelet glycoprotein 1b9 and also platelet glycoprotein 2b3a. So both addition and aggregation related glycoproteins, right? So against both these glycoproteins, autoantibodies are formed. So IgG being an opsonin, right? So IgG is an opsonin. It is going to coat these platelets. So once these are being coated, these platelets will be easily recognized by the macrophages in the spleen, and they are going to be destroyed by the splenic macrophages. Okay. So opsonization related macrophage, it is going to be destroyed in the spleen. So when platelets are being destroyed in the spleen, it is going to result in the thrombocytopenia. So thrombocytopenia is going to result in the bleeding disorder. So you have to remember something here. So the kind of bleeding disorder manifestation in vascular pathology, in a platelet disorder or a coagulation factor deficiency is going to be different. So in vascular pathology, I told it is going to be purpura, ecchymosis and hematoma formation, right? While in a platelet disorder, it is going to be petechiae and purpura again here, petechiae, purpura, along with that mucosal bleeds are common. So petechiae are nothing but pinpoint hemorrhages in the skin. So purpura are slightly bigger ones, okay? So petechiae, purpura along with mucosal bleeds as in epistaxis, menorrhagia, so excess bleeding during menses, hematuria, gum bleed. So these kind of mucosal bleeds are characteristic of platelet disorders. And rarely you can get an intracranial hemorrhage, especially when the platelet count goes below 10,000. So in that case, you can have subarachnoid hemorrhage and also intracranial hemorrhage. So this is the most severe manifestation. Okay, so platelet disorders, it is usually this petechiae, purpurae, mucosal bleeds along with intracranial hemorrhage. And the bleeding here is going to be immediate kind of a bleeding. As soon as there is an injury, there is going to be an immediate kind of a bleeding, excess bleeding usually, right? While clotting factor deficiency manifestation is going to be different. I'll be discussing there when we are discussing the clotting factor deficiencies. Okay. So this is the classical history given for a platelet related disorder. So in the types of ITP are, we have an acute ITP and a chronic ITP. So acute ITP is the one in which a child is usually affected, and generally they'll have a history of some viral infection. So immediately sometime after the viral infection, the kids are going to develop thrombocytopenia, and it is a self-resolving kind of a presentation. So within 6 months, it will go by itself, and here it is going to be of acute onset. So as the name suggests, it's of acute onset, happening in a child post viral infection, and then it is going to resolve in less than 6 months. So as such, there is no treatment needed. Symptomatic treatment will be enough for this. So it is a self-limited condition. While a chronic ITP, it is usually presenting in the age group of 20 to 40 years, especially females. And here it is going to be of an insidious onset. So gradually it will start, and then it is going to be beyond 1 year, so that it is not going to resolve by its own, and usually it is an adult, right? And here you'll have to give treatment for because the IgG antibodies are there, right, acting against the platelets. So for that, you'll have to use steroids or rituximab, which is a anti-CD20 antibody, monoclonal antibody. Then IV immunoglobulins or even splenectomy. So spleen is a site where this opsonized platelets are getting destroyed, right? So you can do a splenectomy as well. So this is the treatment we use for chronic ITP. But as such, if you see, ITP is going to be a diagnosis of exclusion. Okay. You don't have any specific findings here. So there are lots of causes for thrombocytopenia. So initially, you'll have to rule out all the secondary causes of thrombocytopenia. Then you'll have to come to if every test is going to be normal, then you will come for this final diagnosis of ITP. Okay. So what are the findings in ITP you will expect? So as I mentioned, secondary ITP is much more common. So usually any autoimmune disorders, they usually tend to have this ITP. Along with that, CLL. So chronic lymphocytic leukemia, if you remember, there is something called as Evans syndrome. So Evans syndrome is CLL plus autoimmune hemolytic anemia. Apart from that, CLL can also have autoimmune thrombocytopenic purpura. So the autoimmune conditions are going to be more related with CLL. So with IHA, it is called as Evans syndrome, and it can also occur in correlation with the ITP. So that is a secondary ITP. So SLE again is an example of an autoimmune disorder. Then certain infections like HIV. So every cause of thrombocytopenia has to be ruled out before you label a patient as an ITP. Okay. So what are the findings you see in ITP? So the normal coagulation profile I'm going to give here. So the platelet count, as the name suggests here, the platelets are being destroyed, right? So the platelet count will be decreased. So when platelet counts are decreased, the bleeding time will be elevated. Since there is no clotting factor deficiency here, the PT and APTT are going to be normal. Then in the bone marrow examination, if you see, it is going to have, before that I'll see the platelets. In the peripheral smear, if you see, the platelets are going to be decreased, and whatever platelets are there, they are going to be large. So why so? I'll tell. So in the bone marrow, if you see, it is going to be a megakaryocytic proliferation. So remember, it was an immune cause of megakaryocytic thrombocytopenia, right? So megakaryocytic proliferation is going to be there. And these megakaryocytes, you have a characteristic morphology as in, they are going to be smooth. So usually the megakaryocytes are going to appear like this with budding. So characteristic budding will be there. So megakaryocytes will pinch off and give rise to these buds of platelets. But here in this, there is going to be smooth surface of this megakaryocytes along with the hypolobulated kind of a nucleus. Normally, megakaryocytes are going to have multilobated kind of a nucleus. So, and here it is going to be a hypolobated nucleus. So, smooth contours along with hypolobated nucleus. Okay. So, this is a characteristic morphology of a megakaryocyte in a ITP. So, these megakaryocytes are actually trying to produce the platelets, but there is lots of peripheral destruction going on. So, the megakaryocytes will try to release the platelets early into the circulation. So, the platelets are tend to be large in size. Okay. So, these are the findings we saw in ITP.